In this episode, we will ask high-yield questions for differential diagnosis of neonatal respiratory distress. So the very first question is, what are the differentials of neonatal respiratory distress? Well, the first one is neonatal respiratory distress syndrome. The other is transient tachypnea of the newborn. The other is bronchopulmonary dysplasia. The next one is persistent pulmonary hypertension of the newborn. The other is congenital and neonatal pneumonias, and the final one is Meconium aspiration syndrome. Beginning with neonatal respiratory distress syndrome, the first question is, what are the risk factors of NRDS? Risk factors are not only the well-known prematurity, but male infant, infant of diabetic mother, second twin, C-section delivery, and hydrops, the hydrops fetalis. What clinical findings, clues, suggest that we should initiate the workup and management for the diagnosis of neonatal respiratory distress syndrome? This question is important, knowing the fact that it is a clinical diagnosis. Well, findings such as tachypnea for the neonatal level, that's respiratory rate greater than 60, progressive hypoxemia, and symptoms of respiratory distress in the first 72 hours of life. That's symptoms like retraction, grunting, etc. If you have a case of such child, what is the workup? Even though the diagnosis is clinical, we need to order chest x-ray, CBC, ABG, and cultures. Why cultures are important? We need to rule out pneumonia whenever we have an infant with respiratory distress. Now, what are the findings in chest x-ray? They include the well-known reticular nodular or ground glass appearance, but I also want you to remember the second important finding, and that is air bronchogram. Next question deals with the management, and I would like you to always bear in mind that the management of neonatal respiratory distress syndrome is determined by an important factor. What is it? The strength of the neonate's respiratory drive. Okay, so based on the strength of respiratory drive, describe the management. If the neonate has a strong respiratory drive, the management will be non-invasive positive pressure ventilation, the NIPPV, such as nasal CPAP or other means of NIPPV, plus adding surfactant. If, however, infant has a poor or weak respiratory drive or has apnea, then we will start bag valve mask, BVM. Now, once more, what are the indications for bag valve mask instead of nasal CPAP or NIPPV? Apnea, poor respiratory effort, and heart rate less than 100. Next step question for the management. If this neonate fails to respond to bag valve mask, what's the next step? Endotracheal intubation. So, put it simple, we start with NCPAP if there is strong respiratory drive. If there is weak respiratory drive or heart rate is less than 100 or infant is apneic, we use bag valve mask. And if no response to this, we will intubate the patient. What's the important point when we titrate the oxygen supplementation in the neonatal respiratory distress syndrome? In order to avoid oxygen toxicity, we need to titrate SpO2 to levels 90 to 95%, not more than that, corresponding to a PaO2 of 55 to 65 millimeter mercury. Another important question, do we use corticosteroids for the management of neonatal respiratory distress syndrome? No, always remember that contrary to surfactant that we use for the management or treatment, we only use corticosteroids for prophylactic purposes. By the way, do you remember the prophylactic prescription timing for corticosteroids? For the premature deliveries, that's between 24 to 34 weeks gestation, we use intramuscular beclomethasone 48 hours before birth, and if needed we can repeat it for a second dose in 24 hours. That's the 24-hour interval between the first and second intramuscular injection to the mother, 48 hours before the delivery. Now, what are the complications of neonatal respiratory distress syndrome? Remember, these are almost the same complications as other prematurity complications, so they are not necessarily causal or caused by NRDS. It could be just associations, but just remember one important causal complication that's caused by either neonatal respiratory distress syndrome or its treatment is retinopathy of prematurity, as well as barotrauma with pneumothorax. Bronchopulmonary dysplasia, intraventricular hemorrhage, necrotizing enterocolitis, and PDA are the other possible complications. Moving on to the next cause of respiratory distress in the newborn, we talk about transient tachypnea of the newborn. What are the risk factors? Again, C-section delivery, prematurity, infant of diabetic mother if tachypnea is present. Now, if you're asked what is the common pathophysiology between TTN and NRDS, what is it? In both conditions, we have low compliance of the lungs. However, the mechanism of decreased compliance in NRDS is low surfactant, and in TTN is buildup of fluid. Based on this, what is the chest X-ray findings in TTN? Simply presence of amniotic fluid in the fissures manifesting as perihilar streaking. Compare and contrast the lung volume in TTN versus NRDS imaging. In TTN, because of buildup of fluid, we have increased lung volume. In the NRDS, because of collapse of the alveoli, we have decreased lung volume. Each one of NRDS or TTN can happen in mature neonates, the TTN. However, remember, the main mechanism of enlarged lung volumes in TTN is also hyperinflation. What are the symptoms? Again, as mentioned, the most likely term neonate who was born through C-section and has tachypnea and increased work of breathing. Why TTN is not common in newborns of normal vaginal delivery? Remember that normal vaginal delivery is associated with increased catecholamine, and this results in increased absorption of pulmonary fluid. Why TTN is also common in preterm infants? Similar to the condition we mentioned in normal vaginal delivery, in the later stages of gestation, we have an increased catecholamine, and so if a newborn hasn't been gone through those later stages and is born prematurely, there will be residual fluid in the lung fissures. What's the management of TTN? It's usually supportive care, given that it's a self-resolving condition that normalizes within a couple of days. True or false, given the fact that many of these patients with TTN have fluid buildup, use of diuretics could be considered in the treatment? That's false. We don't use diuretics. Next, we have the persistent pulmonary hypertension of the newborn. The persistent pulmonary hypertension of newborn again requires understanding of the risk factors. Please remember that, contrary to many of the conditions associated with neonatal respiratory distress, pHTN is not very common among premature infants. We usually commonly see it in the term infants. Now, also, we have a very specific set of risk factors. One set of risk factors are the risk factors associated with any type of respiratory distress. As you have noticed so far, they could be each other's risk or associated conditions. So we have NRDS, but also we have Meconium strained amniotic fluid, Meconium aspiration syndrome, diaphragmatic hernia. These are other conditions associated with neonatal respiratory distress. One important condition is we have to always rule out neonatal sepsis in these kids as an important association. The second group of risk factors are the type of risk factors associated with advanced maternal age, large or small for gestational age, infant of diabetic mother, or post-term infants, or maternal obesity, or advanced maternal age. And one very specific risk factor that if you hear it, they just want you to know, and it's not very common, but just to know, in utero exposure to SSRI. For example, the mother has depression, and now we has a term neonate with cyanosis and respiratory distress. That's given the diagnosis is persistent pulmonary hypertension of the newborn. Again, what's the clinical manifestation? We have a term infant with the given risk factors who has respiratory distress and or cyanosis. What is the workup in pHTN? Well, similar to other conditions with respiratory distress of newborn, we start with chest x-ray. What is the chest x-ray finding? Chest x-ray is normal. I cannot emphasize enough on this. What is the next step in the assessment, and what's the best test? Next step in the assessment after these clinical and risk factor and normal chest x-ray considerations is assessment of differential saturation of oxygen between upper and lower extremity. That's referred to as pre and post-ductal oxygen gradient. Remember, the diagnosis of pHTN requires more than 10% difference in SpO2 between pre and post-ductal oxygen saturation. Let's think of a vignette. You are given a case of a neonate with respiratory distress and cyanosis, and we will discuss this in our discussion of cyanosis. And you are said that chest x-ray normal, but there is differential saturation of oxygen in pre versus post-ductal measurements. What is your next step and why? The next step, whenever we have a neonate with cyanosis, with or without differential cyanosis, with or without differential oxygen saturation, is going to be echo. Why we need to perform echo in patients with persistent pulmonary hypertension? First and foremost is because cyanotic congenital heart disease is also associated with this cyanosis and differential SpO2 pre versus post-ductal saturation difference of more than 10%. And we need to rule out the cyanotic congenital heart diseases. If the patient has pHTN, what will be the findings in echo? The heart will be normal, but there will be increased pressure in the pulmonary circulation. Okay. Once more, first test, as always in the case of neonatal respiratory distress, is chest x-ray. Confirmatory test is 1 pre and post-ductal SpO2 saturation difference plus echo. We need to rule out cyanotic congenital heart diseases. Now, I would like to draw your attention to this statement here about the severity-based management of the neonates with persistent pulmonary hypertension. If you are asked what factor determines the course of management, remember simply severity, but the severity is determined by this index called oxygenation index. I don't want you to necessarily remember all the details, but oxygenation index is a function of FiO2 times peak airway pressure divided by arterial pressure of O2 and is expressed as a percentage. So FiO2 and peak airway pressure, if they are increased, they increase the oxygenation index. Another thing is if the neonate has low partial pressure of oxygen in the arterial system, is low PaO2, that also increases oxygenation index. And so based on this, we have some values. For example, we say oxygenation index less than 25 is considered mild and usually requires supportive care and addressing the etiology, while oxygenation index greater than 25 usually requires use of pulmonary vasodilators. Do you remember some pulmonary vasodilators? Inhaled nitrous oxide, and next step will be sildenafil if it doesn't work. And finally, if it is very severe, which is an oxygenation index greater than 40, we may consider use of extracorporeal membrane oxygenation or ECMO. The whole fact is just remember there is this oxygenation index that determines the severity. If it is not very severe, manage them supportively, and if it is severe, consider use of nitrous oxide or other vasodilators such as sildenafil. Now, one thing I have not mentioned in this last line here, but I would like you to remember, is that management of all patients, all neonates with pHTN, even if all the findings supports this, requires empiric antibiotic treatment initiation after cultures are taken, because we, as I mentioned, need to rule out pneumonia and sepsis in these kids. So even if it is a mild case, we need to give them empiric antibiotics after blood culture. Okay, moving on to Meconium aspiration syndrome. What's the hallmark? Every time you hear meconium stained amniotic fluid, you should think of this condition in a neonate with respiratory disorder. What demographic we are talking about now? Again, similar to persistent pulmonary hypertension, Meconium aspiration syndrome is commonly seen in post-term or term neonates and not in premature infants. Again, remember, most common risk factor is being post-term but small for gestational age. I would like you to always remember that being post-term or preterm and large versus small for gestational age are complete four different entities. You can be post-term and small for gestational age. You can be preterm and large for gestational age. You can be any of the four possible variants. What's the chest x-ray finding? In Meconium aspiration syndrome, we have patchy atelectasis, consolidation, coarse infiltrates, and possible findings of the complication, which is pneumothorax. What's the other complication of Meconium aspiration? In addition to pneumothorax, we could have persistent pulmonary hypertension. What's the treatment for the Meconium aspiration syndrome? Supplemental oxygen by nasal cannula and empiric antibiotics. Now, if the patient has severe symptoms, what's the next step? If the newborn has apnea or is gasping and have other symptoms compatible with respiratory distress, first try positive pressure ventilation and resuscitation efforts. If the gasping or labored breathing continues despite positive pressure ventilation, what's the next step? Logically similar to what we mentioned in NRDS would be intubation. We have an important indication here. What are the important indications for intubation in a patient in a newborn with Meconium aspiration syndrome? Gasping or labored breathing despite positive pressure ventilation measures or initial oxygenation measures. If the patient keeps having low saturation, if the heart rate is less than 100, and logically if there is other general indications such as airway obstruction. Now, given the fact that we mentioned the most important risk factor is post-term small for gestational age, what's the best preventive measure to avoid Meconium aspiration syndrome? Avoiding delivery past 41 week of gestation and intrapartum fetal heart rate monitoring. Again, induction of labor at around 39 weeks is the best preventive measure. Now, there is a very important factor in the management of the Meconium aspiration, and that is related to the suctioning. What's the ruling? In a delivery in which amniotic fluid is stained with meconium, regardless of whether or not the newborn, the neonate, is vigorous or not, we should not use suction. So whenever you have a case of a meconium stained amniotic fluid with respiratory disorder, respiratory distress in a newborn, don't use suction. What other management point is important? Again, similar to persistent pulmonary hypertension of the newborn, we need to provide empiric antibiotics. Again, in this case, even imaging would not help us to rule out neonatal pneumonia. So immediately after blood culture and tracheal aspirate culture, we provide empiric antibiotics. On to congenital pneumonias and neonatal pneumonias. What are the findings? Tachypnea, rolls, temperature instability, and possibility of apnea. What are the two types? Early versus late. What's the significance of this classification? Early congenital pneumonia that happens within 7 days of birth is usually transmitted by mother, but the late congenital pneumonia could be transmitted as the hospital-acquired pneumonia. The other difference is the pathogens involved. You remember that specifically the most common pathogen causing late neonatal pneumonia, especially in preterm infants, is Coagulus negative Staphylococcus aureus. However, if you're asked what's the most common overall cause of the congenital pneumonias, similar to many other serious neonatal infections, we are dealing with group B strep and E. coli. In general, when tracheal aspirate culture is indicated in any of these neonates with respiratory distress, if they are intubated. So again, we perform chest X-ray cultures that are actually not required for diagnosis, but perform chest X-ray, which is required, as well as lab tests such as CBC, and we initiate the empiric treatment. Here we require your knowledge of not only the most common pathogens as we discussed, but the early versus late onset. So what is the treatment for the early onset type neonatal pneumonia? We provide ampicillin gentamicin. What is the recommended empiric antibiotic for the late onset neonatal pneumonia? We need covering Staphylococcus aureus as well as hospital-acquired pneumonia causes, so we go with Vanco plus a cephalosporin or an aminoglycoside. Can't use ceftriaxone. Note, remember that we prefer not to use it before 1 to 3 months of age, so the cephalosporin that we use includes cefotaxime, ceftazidime, or cefepime. What's the duration? It's usually 7 to 10 days. And finally, we have bronchopulmonary dysplasia. What is it? It's defined as oxygen dependence more than 4 weeks in a neonate with risk factors of bronchopulmonary dysplasia. That includes prematurity, neonatal respiratory distress syndrome, or any reason for use of mechanical ventilation. Put it simple, we cannot either intubate or stop the oxygen supplementation, and the neonate is dependent on this oxygenation supplementation for more than 4 weeks, or you can think of it as the symptoms of NRDS that last beyond 4 weeks. Just a couple final review questions. Do you remember which one of these conditions were associated with presence of fluid with interlobular or interlobar fissures? That was transient tachypnea of the newborn. Which one was associated with clear lungs but decreased pulmonary vasculature? It was persistent pulmonary hypertension of the newborn. Now, if you are provided a condition with neonatal respiratory distress and you are said that the chest X-ray shows low lung volumes as well as air bronchogram, what will be the diagnosis? That will be respiratory distress syndrome. Okay, this finishes our discussion of conditions associated with neonatal respiratory distress.